Hello, my name is William Thatcher. Today I will be presenting on trauma stress-related disorders. We'll review post-traumatic stress disorders, adjustment disorder, and acute stress disorder, and prolonged grief disorder. I'll also highlight diagnostic features, treatments, and important cultural and social considerations. Trauma and stress-related disorders are conditions that develop following exposure to significant stress or trauma. These conditions are important to understand because they impact functioning across emotional, behavioral, and physical domains. In this presentation, I'll focus on PTSD, adjustment disorder, acute stress disorder, and prolonged grief disorder. PTSD, etiology and preference. PTSD results from exposure to trauma such as combat, sexual assault, and natural disasters. Neurobiological changes include dysregulation of stress response systems and heightened activity in the amygdala. Prevalence is about 6 to 8% in the general population, with higher rates in women and military veterans. PTSD diagnostic criteria and features. To diagnose PTSD, symptoms must persist for more than 1 month after trauma exposure. These include intrusive thoughts or memories, avoidance of reminders, negative mood and cognitive changes, and hyperarousal. Flashbacks, nightmares, and hypervigilance are common clinical presentations. PTSD diagnostic differential diagnosis. Differential diagnoses include acute stress disorder, which has a shorter duration, and adjustment disorder, which is less severe. Depression, generalized anxiety disorder, and some personality disorders may mimic aspects of PTSD and need to be ruled out. Treatment. Evidence-based treatment includes SSRIs such as sertraline, paroxetine, SNRIs, and prazosin for nightmares. Psychotherapy such as trauma-focused CBT, EMDR, and prolonged exposure therapy are highly effective. Long-term follow-up is important to prevent relapse. Stigmas can be a significant barrier to care, especially in military and minority populations. PTSD affects men and women differently, with women more likely to develop the disorder and men often exposed through combat. Clinicians must also recognize that cultural groups may express distress differently. Adjustment disorder, etiology and prevalence. Adjustment disorder develops in the response to identifiable stressors such as divorce, job loss, or illness. They're relatively common, presenting up to 20% of outpatient psychiatric diagnoses. Diagnostic criteria and features. Symptoms begin within 3 months of the stressor and typically resolve within 6 months after the stressor ends. Emotional and behavioral responses are disproportionate to the stressor and impaired functioning. Differential diagnosis. It is important to distinguish adjustment disorder from major depressive disorder, generalized anxiety disorder, and PTSD, and normal bereavement. Unlike these conditions, adjustment disorder are more time-limited and tied to specific stressors. Treatment. First-line treatment is psychotherapy, including CBT, supportive counseling, and problem-solving therapy. Pharmacotherapy, such as SSRIs and short-term anxiolytics, may be used when symptoms are severe, but treatment usually focuses on coping skills. Stressors vary across contexts such as immigration and or acculturation. The presence or absence of strong social support significantly affects outcomes. Stigma may prevent individuals from seeking care, particularly in cultures that discourage open discussion of stress. Acute stress disorder. Acute stress disorder occurs after exposure to trauma. Prevalence ranges from 5 to 20%, depending on the type of trauma, and rates are highest after interpersonal violence, such as sexual assault. Diagnostic criteria and features. Symptoms last from 3 days to 1 month after the traumatic event. They include intrusive memories, disassociation, avoidance, and hyperarousal. Duration is the key distinction between acute stress and PTSD. Differential diagnosis. Differential diagnosis includes PTSD, panic disorder, generalized anxiety disorder, and dissociative disorder. Substance intoxication or withdrawal may also mimic acute stress disorders. Treatments. Trauma-focused CBT is the gold standard treatment. Medications are not typically first line, though short-term analytics maybe help manage acute anxiety. Monitoring is crucial because some patients progress to PTSD. Cultural and social consideration. Cultural norms shape how people interpret and respond to trauma. Spiritual or religious framework may be central in discovery. Social stigmas can reduce reporting and delay treatment, especially in cases of sexual violence. Prolonged grief disorder, etiology and prevalence. Prolonged grief disorder arises from the death of a loved one. It affects about 7 to 10% of the bereaved individuals. Risk factors include sudden or violent death and lack of supportive relationships. Diagnostic criteria and features. Symptoms include persistent yearning, identity disruption, and functional impairment lasting more than 12 months in adults and 6 months in children. The disorder goes beyond what would be considered a typical grieving process. Differential diagnosis. Differentially prolonged grief disorder from major depressive disorders and PTSD is essential. Unlike depression, grief centers on loss rather than generalized sadness, and unlike PTSD, it is not driven by trauma-related fear. Normal bereavement should also not be pathologized. Treatment. Complicated grief therapy and CBT are effective interventions. Group therapy can also provide support. While SSRIs may help depressive symptoms, they are less effective in addressing core grief-related issues. Cultural and social considerations. Grieving rituals and expectations vary widely across cultures. In some, prolonged mourning is considered normal. Clinicians must avoid labeling culturally normal grief as pathologic. In summary, trauma and stress-related disorders share overlapping features but differ in severity, duration, and clinical function. PTSD is trauma-focused. Adjustment disorder is linked to stressors. Acute stress disorder is time-limited, and prolonged grief disorder centers on loss. Early recognition, cultural sensitive approaches, and evidence-based treatment are essential in improving outcomes. Here are the references that informed this or that informed this presentation. They include the DSM-5-TR peer-reviewed studies and clinical guidelines on diagnostic treatments. Thank you.